Good morning. I'm Rick Pollack. I'm President and CEO of the American Hospital Association, and I think you all know that we are seeing historic, if not unprecedented, change across the entire healthcare landscape. And that's why we really appreciate your joining us this morning for an important discussion, a discussion about how healthcare is transforming, how market forces are driving this rapid change, and how the hospital field is changing to meet patient needs. We're going to explore what the future of healthcare is going to look like, and the need for exciting new approaches to coordinate care and provide more value. We're going to hear directly from hospital and health system leaders about innovative ways they are working to meet the needs of communities and how they're rapidly adapting to these market forces. And we're going to get some different perspectives and insights from key players that are outside the hospital field as well. And we're going to do all of this and get you out of here by 11 a.m. So before I turn it over to our panelists, I just want to provide a little context, and I'd like to just make 2 points. First, what are the forces that are changing or driving healthcare delivery? Well, perhaps the most significant force is that patients and their families simply want care that is more convenient, and they want it when and where they want it, and they are becoming much more engaged in directing their own care. And we're also seeing new entrants into the healthcare field. Many of them are highly capitalized technology companies like Google, Amazon, and Apple. And some of them are traditional companies that are also highly capitalized, like CVS or Optum, that are expanding their role in the delivery of healthcare services, and they're often competing directly with hospitals. We're pleased that Dr. Michael Howell from Google is here to share his insights and other high-tech companies as well, that they can share how they are changing the variety of healthcare services that are delivered to consumers. From Google, we've already seen how this might range from diabetes management to new ideas for providing health insurance. Other technology companies are actively exploring how their devices, including those that many of you in this room may be wearing on your wrists, can monitor your health status while you're sitting right here or at your desk or in your living room. And there is so much more in the works that will fundamentally change how healthcare is delivered to all of us. There's no doubt that more engaged consumers, advances in technology, and new entrants add up to a dramatically changed healthcare landscape. So that's the first theme. The second theme you're going to hear about is how we're trying to build the healthcare system of the future. And for the hospital and health system field to have an ability to compete in this environment, we also need to change. We need to transform to meet the evolving needs of patients and communities. And that's why today you're going to hear from hospital and health system leaders where they share with you how they're redefining themselves and why some are turning to mergers to fuel innovation and create greater value. At the American Hospital Association, we've created the Value Initiative that is under the leadership of our chair, Brian Granulotti, who you'll hear from in a little while. And it's focused on 4 areas to decrease cost and increase affordability. First, designing and redesigning the delivery system. Second, managing risk. Third, quality improvement. And fourth, operational efficiencies. And I think you're going to hear those 4 themes reflected in today's discussion. And you can find more information on this program on our website at aha.org, or you can Google the Value Initiative. Now, some people have questioned our field's motivations as it relates to mergers and acquisitions. And the fact is that these dynamics are in response to being able to effectively compete with these new entrants that are entering the market and to better serve patients and communities in providing more convenient, efficient, and innovative services. Some of this is also driven by the need to have more scale in order to take on financial risk, and that's required as we move from a fee-for-service payment system to value-based payment. The fact is, organized systems of care are also better equipped to drive quality improvements because they're better able to deploy clinical protocols that reduce variation. And the fact is, these developments are necessary for many of our hospitals and health systems to raise the capital that is necessary to allow them to compete with others that have no problem in that regard. The other fact is that building healthcare systems creates better access to services, particularly when certain hospitals, especially in rural areas where 20% of America's population lives, if we didn't build organized systems of care, there would be no care in many of these areas if they're not part of larger systems. So to make a long story short, realignment in the hospital field is fueled by a desire to lead innovation, to increase value and provide a more coordinated and comprehensive care to our patients and to remain competitive in a rapidly changing environment. In this regard, a 2017 analysis by economists at Charles River Associates affirm that mergers can result in efficiencies that's okay, that mergers can actually result in efficiencies that unleash savings to increase innovation and quality improvement that are essential to transforming health delivery. And their data actually showed that mergers do not lead to a spike in revenues. One really important point that many people often miss in this is insurer consolidation, and that's a major factor in healthcare costs. The American Medical Association's 2018 study on competition in health insurance found that 73% of health insurance markets are highly concentrated. 73% of insurance markets are highly concentrated. And that same study states that 46% of the nation's metropolitan statistical areas have one insurer that controls at least 50% of the market. And these highly concentrated health insurance markets have caused the growth in health insurance premiums that is double the growth in hospital prices. Now, we know that our field is changing, and our field and our hospitals and health systems, it'll look different based upon the markets that they're in and the communities they serve, but one thing is never gonna change, and that's that blue and white H sign that you see on every street and highway in America will always be a beacon of safety and security. And one thing that's not gonna change, and what makes hospitals and health systems unique, is that we will play the indispensable role of organizing the clinical enterprise, the comprehensive clinical enterprise, and serving as a key element of society's safety net. Unlike new and expanding players in healthcare, we take care of everyone that walks through our doors, and unlike other players in healthcare, we're open 24/7. In times of disaster, outbreaks, and tragedies, communities lean on us, and that will never change. We're going to continue to provide sophisticated diagnostics, therapies, and surgeries, and the demographics suggest that that's going to continue to grow. But at the same time, that blue H sign will represent more than a building as we seek to transform to better meet the needs of patients and communities and meet patients where they need the care, particularly in an era where so much healthcare is going to be spent on managing chronic conditions. So today's panelists will explore these and other issues, and our goal is to foster an in-depth discussion about the future of healthcare delivery. That's why, again, we've brought together a number of different voices, and we hope you leave here today with a greater appreciation for how dramatically and rapidly healthcare is changing the market in which hospitals compete. We also hope that you leave here today with a greater understanding of how hospitals and health systems are working to lead the transformation of healthcare beyond our four walls in providing care in a more coordinated manner that is more convenient and more responsive to the patients and communities we serve. We're doing this with a focus more than ever before, and with a focus on keeping people healthy. So let's get started. Our first panel will be moderated by Brian Granulotti, the President and CEO of the Atlantic Health System that's based in Morristown, New Jersey. He's the current chair, as I mentioned before, of the AHA Board of Trustees. Brian actually began his healthcare career as an EMT. And in addition to running a highly respected healthcare system known for its superb quality, he also leads one of the largest and most effective accountable care organizations in the country. He's a passionate advocate for expanding coverage and access. Please welcome me in welcoming Brian Granulotti.
Thank you. Thank you, Rick, and welcome everybody. Thank you for joining us this morning. It's great to be back here in DC. So we've got a limited amount of time because we've got a great panel coming up after this. But I want to take a moment just to give you some context. We really want to focus on three things right now that are changing the healthcare delivery system. One is this notion of the patient now becoming a consumer. The second is I think some really breakthrough things that we're doing in technology, because we've always been really good at driving technology and driving innovation, but it tends to be in drugs, tends to be in devices, and I think we've got some really interesting things happening, and we're going to talk about new entrants. And you know, new entrants are called disruptors, they're called scary in some parts, and I got to tell you, the more we have conversations together, I think hopefully you'll see the more we have in common, and that really gives me a lot of hope for the future. So in order to do that, we're going to have two great panelists here today. The first is Dr. Michael Howell, and you know, he's got a great bio, but you'll notice he's wearing a tie. And he's from Google. So immediately there's something going on here. Yeah. Well, the reason is he's kind of new there. He comes from the University of Chicago, where he was a chief quality officer, but most importantly, an intensivist and a clinician at heart. And he has moved over as the chief clinical strategist and principal scientist at Google. Before that, I mentioned Chicago, but he had various roles at Beth Israel Deaconess and the Harvard Medical School. He's a very active researcher. We've had an opportunity to speak this morning and one other time, and he's published a lot of articles, and you're just like a really smart, nice guy, so that's good.
I hope this is on tape to send to my mom.
Yeah. Sam, on the other hand, is a little different. So Sam Gleck, who I've gotten to know through a variety of things with the American Hospital Association, is the director of Oliver Wyman Health Innovation Center Leaders Alliance, which convenes senior executives across the healthcare sector to work collaboratively on creating a greater consumer value and industry sustainability. But his background's a little interesting. So he is a citrus farmer by upbringing. He's an economist by training and a high-tech entrepreneur by background. And he's a partner at Oliver Wyman. And most importantly, he supervises my niece Haley. So thank you, Sam.
We picked Haley before we picked Brian.
Thank you for doing that. But what I've found Sam to be is very provocative and just a great thought leader on this. So let's get started. I'm going to start with you, Sam, after picking on you a little bit. You know, there's a lot of buzz going around about the patients now being consumers. And, you know, some find that offensive when we talk about patients as consumers. Others find it kind of scary, and a lot of us find it encouraging. Can you talk a little bit about that?
Yeah, happy to. So it's, the term consumer, I think, gets thrown about a lot. And we've been talking about so-called consumerism in healthcare for a very long time, actually. If you go back in the clinical literature, was more than 40 years ago that they first talked about shared decision making, which is really just consumerism at the bedside or in the exam room. The health savings account, or its predecessors, is 28 years old, which was supposed to bring in a lot of consumerism. And frankly, not a lot has changed over most of that in terms of how spending happens, where spending happens. We've made the pie bigger for a lot of reasons, but we haven't distributed it differently. But something really dramatic has happened over the last 10 years. Over those 10 years, total healthcare costs have gone up about 50 or 60%, a significant amount. Out-of-pocket costs have gone up 230%. And so what we've done in a lot of places when we think that we're controlling healthcare costs, particularly in the employer world with all good intention, is shifted costs onto individuals. And when you have what is now an average deductible for an individual that's pushing $1,600 plus, and that's not just in high deductible plans, that's just the average period for a commercially insured individual, they start to behave really differently. You know, it used to be if you were in that commercially insured population that pays all the bills and then some for our system, they shopped, but it was really hospital on hospital. It was, I have a gift card from my employer, and I'm going to decide, do I go here or do I go here? Do I go to this place or this place? And it's why we all had marketing strategies, I think, that looked like I put up billboards by the side of the freeway that say, you know, get your knee here or have your baby here or we're a heart center of excellence. And the reality of it is, when I'm now mostly spending my own money, I'm not shopping hospital on hospital. I'm deciding whether to get care at all. And what I'm doing is saying, do I go to the hospital? Or do I get a new phone this year? Or do I get a slightly bigger place? Or do I get new tires? Or can I pay my rent? And it is dramatically changed, I think, how people behave. And so, you know, that's our view of what real consumerism means. When people are not just assuming that they're going to receive the service and deciding which traditional place to get it, but they're really having to decide whether to get it at all. And that really changes the dynamic. Some for the better. It does cause people to make, in some cases, smarter decisions, but some for the worse. You know, we see without the appropriate support and tools and access to care, they just reduce care indiscriminately, the good stuff and the bad stuff. And I think that's the definition we really have to take. And I think there's a lot of clinicians who kind of bristle at the term consumerism because it makes them feel like a commodity. And I think it's exactly the opposite. What it now means is we have to convince people of the importance, not just of seeing us, but of actually taking the action in the first place. We have to be in the behavior change business, and that raises the bar for everybody.
Yeah. You know, you brought up an interesting point about that decision-making process, and I know that many of us, when we want something, we Google it. Mm-hmm. That kind of helps guide our efforts. And so, you know, Michael, when we think about Google, it's almost become, you know, a way of accessing information. And in the conversations that we were having earlier, you and I were talking a little bit about you know, what Google's trying to do in this space and why they're trying to do it. And you said an interesting thing to me. You said, we want to help. Can you talk a little bit about that?
Yeah, I mean, I will confess that I am one of those clinicians who has a little bit of anxiety around the word consumer, and you know, and I think there's a lot of tension in the hospital and in the clinician community about the difference between a patient and a consumer. But I think for me, these are people who are asking for help, and so if we think about the person, we figure out how to do the right thing for the person who is asking for help in whatever context, we're going to do the right thing. Mm-hmm. And if we think about if we do the right thing there first, and then the next order of priorities that we think about the person who is providing the care, who is at the front line, the physician, the nurse, the pharmacist, the physical therapist, and we help them do their job better, then things will get better. I don't know how many clinicians there are in the room, but it's really hard to provide care. It's really hard. And so if we orient around those things, I think we will do the right thing. And so then let me ask, You know, we get this question all the time of like, why is Google getting into healthcare? Well, let me ask this. So in the room, who's been to a doctor in the past, who's physically gone to a doctor in the past 3 months? Okay. Who's looked online for health information or medical information to find an appointment or find your way to the doctor? Okay. And now, this is the part that will make people nervous. Who's ever gone and double-checked what a doctor told you by searching online? Anybody ever tried to care for family who've had a major diagnosis? Yeah. Who's looked online to help for that? So, and okay, here's the scary one. Anyone ever gone online and looked for something and not told your doctor? Yeah, like everyone has done that. And so people are already coming to us and asking for this help, right? So I've had the experience of many patients and families coming in and knowing what they had because they were able to find it, even for esoteric diseases. I'm a pulmonary and critical care doctor. We have some very, very rare diseases, and people come in and they know and they have this information. But they're coming to us all the time to ask these questions, and so we feel an obligation to try and help the person as best we can with what they're asking for that. And so we think about that. And then as tools like machine learning and artificial intelligence, over the past 5, 6, 7, 8 years, as they've started to work, they didn't really work before. Like they've been around for a long time. They didn't work very well, but now they work. And so people at Google started asking the question of, for those tools, can we take those tools and actually help physicians and other clinicians do the very hard work of providing care? So that's sort of what we're oriented around.
Yeah. You know, it's interesting when we start to think about the way companies like Google have fundamentally just changed the way we do things. And we start to think about the opportunities in healthcare to change the way we do things. And we can all point to, you know, our own favorite thing. Mine's an electronic health record, where I don't think we've still figured that out. But there are other areas that you see. And one of the things that you talked to me about earlier was how innovation is occurring in potential diagnosis, almost as an incidental finding because of big data. Do you want to maybe talk a little bit about that? And then I want to pivot over to Sam and have him talk to us a little bit about other things that he's seeing advancing in the areas of technology that are really going to ultimately help our patients.
Yeah, no, I'm happy to. So one of the, when Google was trying to figure out could some of the new technologies around machine learning and artificial intelligence actually help, they started with a particular condition called diabetic retinopathy. Diabetic retinopathy is the fastest growing cause of preventable blindness in the world, and screening prevents diabetic retinopathy because prevents blindness from diabetic retinopathy because we have good treatments. But care is inequitably distributed both in the United States and in the world. So many countries, and I will say many areas in the United States, don't have people who are able to screen for diabetic retinopathy at all. So my grandmother had significant blindness from this, and in many countries, half of the people who present with this condition present with some degree of blindness, which is upsetting and offensive. And so what the team did is get a bunch of pictures of retinas, have a bunch of ophthalmologists, more than 50, go through and categorize the diabetic retinopathy, which is just this little 5-point scale. And then they were able to develop an algorithm that was as good as a US board-certified ophthalmologist in this one little narrow focus task. Published in JAMA in December of 2016. And then subsequently, this team actually figured out that there was a lot of variation among general ophthalmologists. So the chance that an ophthalmologist agrees with another ophthalmologist about the 5-point categorization, 60%, which is a little agitating as a physician, but it's true of every disease we've ever looked at, anyone has ever looked at. And then when they upgraded to retinal subspecialist expertise, then the algorithm was actually about as good as a retinal subspecialist. So now we have the ability to take this truly niche you don't want 100,000 retinal specialists. Like, we already spend a lot on healthcare. But we want everyone in the United States and everyone in the world to be able to get retinal subspecialist screening. So now we're working on that. But there was a really interesting finding that the team had, which was if you take a picture of a retina and you ask the question of, can you predict that person's risk of 5-year major adverse cardiac events? It turns out it predicts it quite well as if you had a score with cholesterol and blood pressure and things like that. And which is really surprising that you could do that. But as a clinician, I think about this and I say, well, you can see the blood vessels. Like, the blood vessels are connected to the heart. So I can believe that you could do that. But one of the things that they found in this was that they could predict with about 97% accuracy whether a retinal picture came from someone who reported their sex as male or female. Any ophthalmologists in the room? Any physicians in the room? Oh, yeah. So that's crazy, right? Like, you ask you tell an ophthalmologist this, and they look at you like you've literally gone insane, and then you give them a bunch of pictures, and they still can't do it for it. And so why is that? Why is that interesting? Well, it's interesting. There are easier ways to determine self-reported sex, like ask. But it's a biomarker that we didn't know existed before, and that humans can't see. And so what it should do is prompt basic scientists in universities and in pharmaceutical labs to figure out why. Like, why can we see that? So I think as we start to see this kind of technology applied to CAT scans and MRIs and pathology, we're going to start to have these new things in the way that today we talk about precision medicine being genomics and genetics, and they change your cancer therapy based on all of this, CAR T therapy, all those things. I think we're going to start to see new kinds of biomarkers that didn't exist before. And so although our group primarily focuses on how do we help patients and consumers and physicians and other care providers, we're starting to see these like fundamental discoveries that I think will be really interesting over the next 10, 15, 20 years.
You know, Sam, you and I have had these conversations about the waste in healthcare. We've just heard Dr. Howell talk a little bit about this concept of new biomarkers and the promise that gives. But technology's impacting a lot of other things that are related to how the consumer is interacting with us. And ultimately, hopefully, that's part of the equation about how do we meet the demands that we're going to be seeing with the baby boom generation and other things to do this. So if you want to give us your thoughts on that, because you guys have done a lot of research on this.
Yeah, happy to. And I'll give a couple of examples and then sort of talk about the big picture. Some of what Dr. Howell is talking about really just fundamentally changes the competitive environment, I think, for healthcare and the kind of care people deserve to get. We still live in a country in which the single biggest determinant of your lifespan is your zip code. And that has a lot to do with your income level, but it also has a lot to do with the care that's available to you. And mental and behavioral health is a great example of that to me. Nearly 60% of countries in the US do not have a single licensed behavioral health clinician. Let that sink in for a second. 60% of counties do not have one person who is a licensed clinician around behavioral health. But what we know is that is the thing that we spend so little on that it costs us a lot. When you look at claims data, we spend something around 4% of our dollars on mental and behavioral health. We know that when you have appropriate mental health care, it can save something like 23% of total spend. Right? It's the biggest thing you can do in many cases to help reduce spend on chronic conditions like diabetes and otherwise. The expensive way to address that would be to go hire armies of behavioral health professionals and then somehow convince them to live in the most rural areas. And while they're doing that, convince them that they can maintain a standard of practice and maintain education and a community and that they want to raise a family there. And it's tilting at windmills to do that. And so it's been an area we've seen incredible innovation around, for example, not just traditional telemedicine, the kind of video visit, but text messaging, cognitive behavioral therapy, artificial intelligence that can engage in a conversation with somebody. And we have real innovators that are out there doing that right now, and we could kind of rattle them off. I think what's been surprising about that is that started as an access solution. It was the only way to get something out. But frankly, people think of that stuff as kind of the next, it's the last resort. It's the thing you can do if you can't get care out there. And what we found in many of those mental health solutions is that people actually like them better. And there's a number of reasons for that. We've seen instances where, in fact, cognitive behavioral therapy, which we know when paired with an SSRI is the magic combination for a lot of anxiety and depression, you get 30% better compliance when it's on a screen as opposed to in front of somebody. Well, why is that? Most of America can't walk in 9 to 5, and the CBT bot is available 24/7. It depersonalizes it, so you're more willing to be vulnerable. It remembers things session to session without having to flip through the chart, right, and make you feel like you're just another one coming through. You can do it at 2 in the morning. You can do it while you're sitting with your mom who you may be caring for, right? There's a lot of reasons you bring that through. We've seen similar experiments with veterans where AI can actually detect 20% more cases of PTSD than the military's post-discharge screener can, right, with an avatar. Some of that's because the science is better, but some of that's because people engage better. And I think that's what's most exciting about what we're seeing, which is this isn't just an opportunity to plug an access gap or makes things cheaper, although there's a lot of opportunity to do that. I think, Brian, as you and I have talked about, 6 out of 10 people who work in healthcare now never touch a patient, never engage with a consumer. Now, some of that's research, and some of that is very needed, but a lot of that's overhead, frankly. And that's the other side of this story, which is, the Cleveland Clinic will tell you they have 2,000 people who do nothing but revenue cycle management, right? That feels like an AI problem. And we could sit here and debate what do you do with the money you pay those 2,000 people, but I'd sure like to see some of it go back into care delivery. I'd like to see some of it goes into those kinds of solutions. So, it's both sides of something that's really exciting, but, I think we see an opportunity not just to innovate around access and around the science, but really innovate around the experience and how we get people more and better care.
Yeah. You mentioned access as a concept, and then a pivot back toward things that were, again, incidental findings or incidental uses for things. Healthcare seems to use technology, and I'll talk about the electronic health record since I like to whine about that all the time, seems to use technology not to disrupt itself, but to simply either facilitate the way we're paid or the way we record and document according to the rules and regulations that we face. So if you start to think about technology in a different way, what advice do you have for the field on how we can begin to change that dynamic and really see substantive change? And what have you seen out there that gives you some promise?
Yeah, I challenge the premise a little bit because we do a funny thing in healthcare that I don't think other industries do, which is we separate clinical technology from administrative technology. We act like those are 2 different things. We have had incredible innovation in the exam room, in the hospital, in the operating room, in imaging over the last 40 or 50 years. There has been probably no greater technological innovation, internet included, than some of the things that we are able to do that are downright magic inside of the places where we deliver care. Now, on the other end, we have taken all of that wonderful innovative thinking and somehow left our brains at the door when we design the administrative technology that goes around it. And it's led to this kind of very disheartening phenomenon, which is over the last 30 years, there are only 2 industries that have declining productivity per employee. And that's been healthcare and education. And there's a lot of reasons for those similarities. That's probably a different panel discussion. But what that means is in healthcare, we've added technology and we've added people around it. We don't take a mindset that the goal of technology in almost every other industry is actually to displace people, bring costs down, and then think about how to redeploy those resources for the benefit of the individual. So what makes me optimistic about where we're headed, kind of from here? How do we keep that curve from growing? In part, I think there's more of a realization now that that's exactly what's been happening. And frankly, the demographic wave that's coming through this country makes the economics that we have in a typical health system, frankly, not sustainable. I mean, we live in a world today in which, you know, the commercially insured, the people employers pay for, are about 1/3 of the volume, 2/3 of the revenue, and 300 to 500% of the profit. And so what we do is we take 1/3 of the volume and we use it literally to pay for everybody else. That works as long as that demographic is growing faster than the ones we're subsidizing. That's not true anymore. Depending on the market in this country, you know, those in Medicare are growing at 2 to 4 times the rate of the commercially insured. You don't have to be an economist to draw those lines, right, and see where they cross. And so there's a lot of realization that we're going to have to deliver not just the care, but literally the whole package in a way that's a lot more efficient. And we're starting to think about that, which is exciting. You know, the other thing that really is exciting is what Dr. Howell and others are doing, which is we are seeing big players come in and genuinely make healthcare nationally competitive on every dimension, where healthcare is no longer a bricks and mortar business, it's an information business. Because it may seem like a neat trick that we could tell sex from a retinal scan, but when he can do a lot of other things with that information, that means we don't have to build a facility necessarily to do that. That's the technology really adding value and changing how we provide access. And I think there's a huge opportunity there that's really exciting. And whether that's, you know, when we see CVS and Aetna with 10,000 points of presence across the country trying to be the front door to this whole system, or whether it's, you know, I think Rick mentioned, you know, Optum and DaVita, which if that deal closes, they're the largest employer of the physicians in the country, bar none, right? Nearly 40,000 physicians. And that's the part of the system people really care about, which I think is, you know, it's interesting. We in the system tend to take a system view. If you look at where healthcare costs go, it's 38-ish% goes to hospitals. If you look at where people spend their out-of-pocket money, you know, the thing that influences their behavior, only 9% of that goes to hospitals. They spend 50% of their out-of-pocket money on drugs and primary care. That's the thing they want, right? That's where their out-of-pocket dollars go. And that's the thing we have to make accessible to them. And that's where being an information business is incredibly powerful. You know, whether it's pharmacogenetics that can tell me which drug I need and I don't have to go through 5 choices before I get to the one that works for me, whether it's primary care via AI, which the National Health Service in the UK is doing, so I can interact via chat in the middle of the night and it can tell me if I need to go in, whether it's the retinal scan that I otherwise just wouldn't get. It's exciting stuff. It's a fun time to be in healthcare.
Now, you, as I mentioned earlier, still wearing a tie at Google.
By the way, I did not wear a tie because I was going to be up here with the Google guy.
Your predictive model needs some calibration.
Yeah, thanks.
So, you know, you crossed over the threshold from some, as was mentioned, legacy organizations to an area that's got to be just fascinating for you to learn how they learn and how they advance. So what lessons have you learned that you would say, if you went back to the University of Chicago, you'd say, hey, folks, we got to be starting to do things in a different way, and what would that be?
Yeah, so that's a good question. So, you know, I will say sort of in mid-career to suddenly have a year and a half where your learning curve is completely vertical again is such a joy and a blessing that it's been pretty amazing. Actually, I think that many of the lessons that I would take away are non-technical lessons. They are lessons about, you know, the way the company works, around information and data that we have about what makes a high-performing team, which is, you know, as somebody who has worked on patient safety and quality for 20 years in healthcare, I sort of knew, but there's better information about it at Google. The answer is it turns out to be psychological safety for the team. It determines performance. And I think that, you know, I've gotten to meet with many more health system leaders than I did working at a single center, even though I worked with the AHA and other folks. And I think I would take back that innovation is happening in a tremendous number of places in a lot of different places, in a lot of different places, and that it's likely that one of the roles that large technology companies will play is to enable that innovation to go faster in lots of different places. And I think that's one of the things that we think about internally is how do we make it easier for people to take this and use it in their local context.
What do you think about that, Sam?
Yeah, I think it's spot on. I think it's interesting to be on both sides of this conversation. When you spend time with the innovators, and we keep track of about 1,000 innovators, and most of them will become nothing near Google. In fact, they won't be here in a few years. But if you believe the statistics, about 1 in 20 of them are going to make a real impact. And when you talk to them about what their frustrations are, it's not raising money. There's plenty of capital for good ideas. It's not even finding talent, right? There's actually plenty of people who really want to have a purpose around helping to change health. It's not the science of what they're doing. They're actually quite engaged in cracking that problem. It's why does it take me 15 months to find the right person to talk to at a health system? Yeah. Right? That's what they say. The other side of that is you then go to the health system and they say, why are all these innovators going to somebody else? And who are they engaging with? And some of that is the way we've designed health systems, which is many health systems in this country have come up from being individual community players that have come together in kind of federations and are going through their own evolution of do you have single governance and do you have single management, and how do we think about at what level different things happen. And when I'm an innovator who's trying to be a scale information player, and frankly, you may have more people that I need to talk to than I have employees, having one point of contact and one kind of centralized function that can have that conversation is really important to me. There are regulatory barriers, frankly. One of the funny examples we have recently was a client who was looking to provide a pretty innovative transportation solution. They realized that many of their patients, the biggest problem was getting them into an appointment. They went to partner with an innovator to do this. Their lawyers came back and said, Stark says you can't provide a ride to the appointment, but you can send them home. That's a true answer, by the way. It's inducement if you're bringing them in, but once they've come, you can send them home. Right? And so there's some kind of funny regulatory barriers around that. Some of that's privacy. But it's well-intentioned people on both sides. And I think part of what we have to get good at is how can we have those conversations in a more streamlined way? How can health systems decide what they want to be good at versus where they're really looking for partners? So it's not about just fielding whoever sends you an email that morning, because there's a lot of those emails coming in. And then, how do we together tackle some of those challenges? Because everybody's got good intentions and headed in the right way, but right now it's this kind of small to mini conversation, which makes it hard.
Yeah, I've heard that comment most recently. We were at South by Southwest, and we were having a panel, not unlike this, and that notion of how do we actually interact as hospitals and health systems with organizations that are could be viewed at one end of fragmenting an already fragmented system, or at the other end, a real resource to begin to think about how do you work shoulder to shoulder to be able to help, back to the Google comment, our patients. And that seems to be the great divide right now, is how do we moderate, or how do we mediate that, or how do we create the environment to do that. And one of the things we're trying to do at the AHA is put a spotlight on that conversation and create the mechanisms that can be in place so that our members can do that. Because the very large systems, like the Henry Fords and the Providences and things, have brought folks inside from those worlds, have organized mechanisms to develop that, but that's not where the bulk of America's hospitals and health systems are. And getting back to the Blue H, ultimately that's really when in urgent need people turn. And that's the dilemma that I think we have in healthcare today, and we've got to balance that, because I do think, and we talked about this earlier, Michael, the system is fragmented right now, and the real question is how do we partner so that we can take a fragmented system and make it more oriented to the patient and the consumer, at the same time being able to use technology to drive costs out of the system rather than add cost, so that we can deal with this wave that's coming at us by folks like me who continue to get older and older and are about to hit that point. So just before we go to the questions, why don't you guys talk a little bit about that? What can we do differently? What can we do differently? You've been on both sides. You see both sides. What would you suggest? Because you got some healthcare leaders here.
Please.
That means they don't have answers.
I
They're
got
just
answers.
passing it back and forth.
Yeah, I think that Sam's point about the variation in engagement that sometimes feels arbitrary in terms of what the lines are to color inside, I think is a really important one. When I was at the University of Chicago, which is a sort of reasonably sized health system in the south side of Chicago, a bunch of patients who wanted to come to us or to have local care are in a different state. Mm-hmm. And so, we employed human beings, more than one, just to do the paperwork to make that happen. And, replicate that 4,000 or 5,000 times. And so I think that there's an intersection of policy approaches to help simplify some of these things, now that I'm not worried about 2 or 3 states, but about 50 states and territories and other things like that. Having a common approach to these kinds of things, I think, is really helpful. Mm-hmm. And I think that the understanding, which I do think that the AHA is really taking leadership in here, that things will be different in 10 years or 20 years, right? There's this great quote by Bill Gates of, we always underestimate the amount of change in the next 2 or 3 years, and we overestimate the amount of change in the next 2 or 3 years, and we underestimate the next decade. And I think that the people in this room and the people who are your constituencies, and then companies like us, we all get to help pick the path that goes forward. We should pick the path that helps the people who are asking for help, I think.
What do you think, Sam?
Yeah, I think Michael's spot on, and I'll give you the advice that I would give, any health system, and then I'll tell you the innovator side of it, which is
This is free, by the way.
This
is not a typical Oliver Wyman.
That's what you think. We have clipboards at the back. No, there are a few health systems in the country that I think have the luxury of doing everything. Of nearly everything, but that is the very small minority. And I think health systems increasingly need to separate what their mission is from their decision about who provides it. That if you ask the question, if you said, if our mission is to make sure that everybody in the community we serve has access to the care they need, full stop. Second question, what of that should I provide? Versus what of that do I need to make sure they have access to from a place that's better equipped to provide it? And I think that's where this conversation gets interesting, because there isn't as much clarity about that as there should be. There has been a bit of a default assumption that if you want to make sure everybody has access to the care they need, you need to provide a little bit of everything in order to do that. And frankly, particularly in a world where we now have national broadband and scale players and all of that, I say some of that I'm going to be really well equipped to provide, and I want to compete, and I want to do that. And some of that I'm in an information business. My job is not to figure out how to hire 3 physicians who can do what I need in that community. My job is to have a real understanding of what that need is, how people really want to consume it. Is it in their home? Is it at a community center? Where is it? Market the heck out of it so that people get in, and then find the right player and match them up with it, and be in the place of managing their overall care for that place. That then changes the dynamic. So when those innovators approach, you have a list. You're out there looking for it. You're not necessarily saying, well, that's kind of neat. Let's see where that goes. And that's a hard conversation to have, but it fundamentally provides better care. One of the stories that has always stuck with me and actually haunts me a little bit is these jumbo employers are starting kind of centers of excellence, as we've seen, where they'll send people, and there was a great Harvard Business Review article about Walmart doing this that came out last week, send people to 8 or 9 places across the country to get better care. And there's an employer who did the similar thing, but they did it for cancer. And what they said is if you get a cancer diagnosis from a local community oncologist, we'll send your chart to a center of excellence and actually have somebody take a look at it who's a national expert in that. They then did a retrospective study to see, well, how much better are we making things? And they found that 1 out of 5 of their employees who was diagnosed with cancer in a local community and treated, right, because it's retrospective, either didn't have cancer or was diagnosed with the wrong one. Right? It's haunting. And those are well-intentioned, well-trained clinicians. Right? Those are well-intentioned, well-trained clinicians, but there's no way they can be as good as somebody who looks at a subspecialty all day long and then takes that to the next level. And we've got AI that's so much better than the subspecialists even are in some cases, looking at a very narrow thing. And that's what I think the local health system have to do. You have to say, I am not going to be able to do that as well. My job, what I'm really good at, is getting them access to that and then bringing them in to scale solutions. On the innovator side, I think it's the flip side of that, which is know the thing you're good at and know how to say it over and over again. There's a lot of them who go broad before they go deep, and that can be really frustrating. And that's how you match up on the other side. But I think if you do that, we're going to have, I agree with Michael, I think over the next decade, the conversations are going to look really different and for the better.
Good. We've got about a little less than 10 minutes for any questions from the audience, comments, thoughts. If not, I can continue to torture them. Go ahead.
I'm Jack Millen, internist who kind of migrated to cardiology. But I'm chairman of the board of the National Coalition on Healthcare. And as you see, CVS purchasing Aetna and some big shifts in the marketplace, do you anticipate somewhat of a disintermediation of primary care, or at least a new model of primary care, where the physician side of primary care becomes more a concierge service, and we provide a different kind of, maybe more convenient service in another way, connected with telemedicine to specialists and so forth? Do you see something like that emerging?
The disintermediation term I sometimes question a little bit. I think we're seeing a revolution in primary care. I think we absolutely are. The reality of it is, because of the cost shifting that it's happened, it's already happened. So 2 years ago, we got to a point where your typical commercially insured person who is generally well in a typical year was paying all of his or her own healthcare costs, period, right? You got deductibles and coinsurance and copays to a point where they're paying all of their own healthcare costs. And we saw this. We had the privilege in being involved. This was pre-ACA in a lot of the original business cases for some of these retail clinics. And the business case for those, I'll tell you, we got completely wrong. The business case was there are 40 million other uninsured Americans who are going to be looking for a new attachment point to the system. Retail clinics are going to be it. Let's build them. Let's bring them in. And what happened was, when they were built, was 2/3 of the people showed up who already had insurance and actually could probably pay a lower copay to go somewhere else because all the cost shifting hadn't happened. But they wanted to be able to take their kid for a sports physical at 9 a.m. on a Saturday. And it was more convenient to pay $49 to do that than to wait 3 weeks and pay their $20 copay. Right? That was what was coming in. Now, there's a say-do problem in this new primary care. So we go out every year and we do a big statistically significant consumer survey. And people tell us in droves, in every segment, from millennials to seniors to everything in between, that they want retail, they want urgent care, they want concierge, they want telemedicine. And then we ask them, have you ever tried it? And very few of them have. We're still having to get that offer design right. Some of that is where we put them. Some of that is the hours that we have. Some of that is, with telemedicine, there are very clear barriers to telemedicine, but the biggest one is your first visit right now requires that you use your thumbs for 15 or 20 minutes and enter your medical history, which is not when I want to do the first time I want to use it, which is usually when I have the flu at 2 in the morning. Right? So there's a lot of barriers we got to get out of the way in terms of offer design, but there is a ton of latent demand. So I think, I'd say that's happening, but I would flip the term, which is, it's not somebody coming in and disintermediating. It's consumers saying, darn it, I want to buy that differently, right? Darn it, I want something that's more responsive, and I'll give you a little cash to do it. And I think we just got to design the right offer.
Excuse me.
Other questions? No questions. All right. Okay, yes, go ahead.
Hi, so I'm Josh Sylvan. I am not a healthcare practitioner. I'm an antitrust lawyer. I do work for the AHA. But I do work in many other industries as well, including representing Google. In many industries, it seems to me that improvements in efficiency and quality occur through competitors dramatically and aggressively reverse engineering what their competitors do, that process occurs across the economy so that the best ideas and the most efficient ideas quickly propagate out across the firms in a sector, and that drives costs down and improves quality at lowest price. It's not clear to me, through no one's fault, that always happens in the healthcare industry. And so a lot of the ideas that may be happening in Box A or in State A may not make their way over to State B. It seems to me that technology offers an opportunity to improve on that. So your thoughts on that would be great.
Yeah, we almost went in this direction a little bit during the conversation earlier, that there is this idea of the productivity paradox, that as we've added technology to healthcare, productivity has gone down. And I think those of us who've lived in healthcare for a long time say, oh, that's because we're special. But actually, it turns out that's happened industry after industry over the past 100 years. That when factories were first electrified, productivity didn't go up because they just replaced the giant water wheel with a big electric motor. And it wasn't until 10, 15, 20 years later that people figured out how to re-engineer the work with the new technology. And then in manufacturing and banking, we saw the same thing, that it took 15 or 20 years. Well, we're getting there now in healthcare, right? We have moved from a place where, 10 or 15 years ago, 90% of your health record was on sheets of paper, and today 90, 95, 98% of places you go are electronic. And I think we had a piece about this in JAMA back in July, that I think we're at this place where if we're like other industries, we may actually redesign care that incorporates the new technology, and we're historically at about the point where that's likely to happen. So I think that my read is that we're at I'm an intensivist, so I'm sort of naturally skeptical, worried all the time. But I do agree with Sam that I'm hopeful, actually for the first time, about the ability for the industry to redesign itself and incorporate the technology in a way, which, to go back to your actual question, that I think will help the idea spread in ways that we've not really seen before.
Yeah, I think that's a great point to land on, this notion of optimism, because I think we all have experienced the healthcare system either directly or through family and friends, and understand that it's there for us, but it's really hard to navigate. And then when you guys, particularly Sam, starts throwing out statistics, it gets a little scarier. I think that is what is motivating all of us who work in the field to do that, and we're all approaching it a bit differently. I think over the last several years, what has made me optimistic is that I'm seeing change in our field. I'm seeing organizations kind of take this, but most importantly, I'm seeing these kinds of conversations occurring. I call it an honest mirror, because the risks are too high for our communities to not engage in what are uncomfortable conversations. The second piece of that, which I also think is a good thing about forums like this, is that we also have a blend of folks who work on the Hill and who regulate us. And I think that the comments that were made during this discussion about making sure, and got an antitrust person here, et cetera, to make sure that as we are working collaboratively to better serve our communities, that we make the necessary accommodations in law and regulation in order to enable that. Because we have a healthcare system that was designed around payment systems. And we need to move to a healthcare system that is designed around the needs of our communities. And that's really what we're trying to do through these conversations and others. So thank you for joining us today. Thank you all for listening to this piece. And don't go anywhere, because the next panel is going to be even better. So thank you.
Thank you.
So thank you very much, Brian and Michael and Sam, and I think that Brian really nailed it on some summary points there. A couple of other takeaways that I think you probably heard there is really the potential of partnerships. Partnerships between those in the hospital and health field as well as those in the technology sector. And, you know, it really is interesting. Technology is a marvelous thing, isn't it? It's just incredible what it can do. And if you think about technology, you know, you're able to do things that human beings can't do. It's kind of like a car. You know, a man or a woman will never go as fast as a car. And technology is always going to be smarter in some ways than the human being. But one of the things that technology in all its glory can do in terms of aggregating and retaining information is that they don't have technology doesn't actually provide the wisdom. It can inform judgment, it can provide better options. And I think one of the challenges we find in healthcare is that notwithstanding the fact that we can, technology is a pathway to reduce costs and improve care and maybe take out some of the overhead, machines can't take care of people in an empathetic and compassionate way. And that's one of the challenges we've got as we try to embrace technology, but don't lose the essence of really what our doctors and nurses and all of the clinicians do every day. Our next panel is going to look at the future of healthcare in terms of the H of the future in the midst of this changing landscape. And our moderator is the highly respected thought leader, the managing director of Kaufman Hall, Ken Kaufman. And he's one of those people who you always learn from whenever he talks. He's not only really smart and insightful, but he's deeply involved in advising healthcare leaders and helping them prepare for the future. And he can also be really funny, even though this is no laughing matter. Anyway, he's the perfect person to moderate this conversation. Please join me in welcoming Ken Kaufman.
Thank you very much. It's really good to be here. I want to thank the American Hospital Association for inviting me to be part of this great panel. So we're going to take it to a little different level here now. I think the last panel was fabulous. There was just some really tremendous ideas there. But we're now going to talk to the people who have to actually make it happen. And there isn't any possible way I can overemphasize to you how hard it is to run a large healthcare organization in the United States right now. I've had the great privilege for over 40 years to consulting to hospital leaders all over the United States, and I have the absolute highest regard for the work that they do and how hard they try under what would be described, I think, at this point as very difficult and trying circumstances. So that's what we're going to try to put out for you. So we have three terrific panelists. We have Elliot Joseph in the center here. And Elliot is the CEO of Hartford Healthcare in Hartford, Connecticut. And it's Connecticut's, one of Connecticut's largest and most comprehensive health networks. We have Wright Lassiter. And Wright is the president and CEO of the Henry Ford Health System in Detroit. And Henry Ford is comprised of 6 hospitals, a very well-known health plan, and more than 60 clinical locations. And then next to me, Dr. Janice Nevin, who is president and CEO of Christiana Care Health System, which is the largest health system in the state of Delaware. So before we turn to the questions and discussion, I'm just going to like to make a few introductory remarks to this panel. So in a disruptive environment, organizations of all types, especially legacy organizations like hospitals, need a way to organize their thinking about the future. And Jim Hackett, who is the CEO of the Ford Motor Company, developed a very powerful way of setting up that thinking process while he was the CEO of the Steelcase Company. And his concept is called Now, Near, and Far. And what he says, what Jim Hackett says, is now we have to be successful in the now while figuring out how to make the critical pivot to the far. And in the near, we have to figure out what bets we're going to make on the future and how we begin to allocate those resources to the future, even while we're still continuing to run our existing organization in the current business model. And then the far, which is the most important, is every healthcare leader in the country, including the three on our panel here, have to figure out what the future state and the future role of their organization is, knowing that as disruption takes place in the healthcare field, any prediction is uncertain and likely to be subject to change. Hackett insists that companies need to consider all three of these dimensions simultaneously, which is a new business challenge entirely. This is very difficult when now is in one business model, the current reimbursement business model, and far is going to be an entirely different business model. So you're running an organization for now while you're trying to figure out how to move it to far. It is even more difficult when the largest, most tech-savvy companies in the world are in an arms race for breakthrough ideas. In healthcare, we see a new breed of companies trying to figure out the far. United Health Optum and CVS Health Aetna are trying aggressively to unbolt the outpatient healthcare business from legacy hospitals, allow it to float free in the competitive environment so they can obtain as much of that business and as much of that revenue as possible. Amazon, Apple, and Google are investing heavily in healthcare from numerous angles, looking for the most effective entry point. Hospitals are trying to envision their own role in far and what actions are required in the now and near to reach that far. The most important part of this pivot to far is an attempt to gain the financial and intellectual resources to compete with these very large new competitors, many of whom are many times larger than the largest not-for-profit health system. And if you want some context for that, United Optum and CVS Aetna are more than 10 times, 12 times larger than the largest not-for-profit healthcare system in the United States, let alone what goes by your local community hospital. Hospitals are making this transition in the face of a difficult financial reality. The Moody's 2019 outlook shows revenue growth for hospitals will continue to decline under pressure from weak inpatient volume and declining reimbursement. This puts hospitals in an extremely difficult competitive position. Now, the normal response of any company in any industry would be to seek scale to meet this different level of competition and adjust to a coming new business model. Scale that would allow an organization to get the best intellectual capital, to get data analytics, and then to test and scale the very best new ideas. So with that backdrop, let's hear from our three CEOs now as they talk about how to pivot their organization from now to near to far. So let's start with a question for all of you in turn. Who do you see as your most significant competitors to hospitals and health systems over the next 5 years? And what do you think it's going to take for your organization to stay competitive in this fast-changing environment with new, very well-capitalized organizations coming into healthcare? Who'd like to start? Right? You want to start?
Sure, happy to. Morning, and Ken, thanks for the question. You in your preamble, you gave a bit of context around the competitors and disruptors, new entrants in the healthcare, and so clearly organizations that are trying to disrupt our ambulatory environment, the outpatient realm of care, are probably the most significant competitors for healthcare. The notion of sort of disaggregating ambulatory and inpatient care and thinking of primary care or ambulatory care as separate and distinct from the inpatient setting to some extent creating, disrupting the system of care. To create ambulatory care as a separate animal is probably the most significant competitor when we think about the current reimbursement model and the current model of care in healthcare. And so if you think about hospitals sort of beginning as principally inpatient animals, evolving over periods of time to trying to create a coordinated care model for both inpatient and outpatient medicine, and with that potentially being disrupted, you know, the natural response of healthcare organizations is to try to create greater efficiency, greater attractiveness, and reduced cost in that segment of their business that's being competed against. And I think that the prior panel, as Sam talked a bit about, organizations need to think through what they do well and what they need to partner with. You know, I think that what we're trying to do, for instance, is sort of thinking about how do we reimagine access to our system through primary care. Henry Ford is an organization that began as a very integrated model with employed physicians and a single hospital, and frankly, in our early days, really no outpatient care. We were doctors who had clinic settings that fed the inpatient environment. If we just maintain that historic approach of a employed model tied closely to the inpatient environment, that would not serve Southeast Michigan and Michigan residents particularly well. And so for us, we're looking both at how do we reduce our brick and mortar approach to access to our system through technology, through virtual care, but we're also looking at how do we extend our network beyond those physicians who are employed and tightly organized around our hospitals to folks who are out in the communities where our patients need the care, but focusing on how do we create that fiber of connection that ensures that the system of care maintains a level of integrity. And so as you think about managing data and managing the information flow around that patient's health, we're trying to ensure that as we extend ourselves into broader and broader communities, at times with physicians who are not in our traditional model of employment, that we still have a way of managing the totality of care on a longitudinal basis. And so that's my first answer. I could speak more, but I'll give my panelists a chance to answer.
Great.
Yeah.
Janice?
Yeah,
Go
so
ahead, sure.
I would say, you know, we've always had competition in healthcare. And I would argue there's even more competition in healthcare currently. And a lot of it has been driven by these new entrants. And I think, you know, the reaction could be sort of double down and sort of retreat and compete in a space that we're comfortable with. But what we're doing is really embracing this new competitive environment. And frankly, I think there's an opportunity to engage in a way that will truly make us better. So at Christiana Care, you know, if I were to sum up our strategy in a word, it would be value. And we've defined that in a very person-centered way. So it's about how do we help people, the people in all of the communities that we serve, achieve the health outcomes that are important to them, and do it in a way that really respects cost so that we can create affordability. So I think very similarly, we've talked about, you know, being a great hospital system and clearly need to continue to fill that need, where it's about hospital beds, evolving to great health system where it's, you know, how do we care for lives, to truly in the future, how do we become that system that impacts the health of all of the people who live in the communities that we serve. So really thinking beyond the traditional definition of sort of patient accessing care, but really becoming deeply engaged with people and with communities so we can make a difference in health. And that is all about, we have these conversations, you know, in 2025, will we be a data company that happens to provide health care and impact health? And so I think the opportunities are to really leverage what our advantages are. I mean, we are with people at the most vulnerable points in their life. whether it's the joy of creating a new family or it's end of life. We have relationships with people who live in those communities. They know what their issues are. And if we can engage with them, we can help together sort of sort out how do we use this new technology to truly make a difference. And then we have the data. So we've got an opportunity, whether we're doing it ourselves if appropriate or doing it through partnership, to again, what's the system that we need to build? What are the solutions that we bring into that system that ultimately create value and impact health?
Elliot, how's this look to you?
A lot of similarities. I'd say like others, the folks that we're paying attention to are these vertically integrated for-profit companies who have tremendous amount of talent, capability, capital, and often are playing in a different regulatory field where they are freer to move in the market than many of us are as not-for-profit health systems. So that's kind of our reality and who we're watching closely. But at the same time, we're not thinking about this as a defensive thing. We're thinking of this about being on offense.
Talk about some of the offense.
Yeah, so back 11 years ago, we created a vision, because your near, now, and far thing is beautiful, right? I just couldn't agree with anything more. We said our vision was going to be most trusted for personalized coordinated care. That was our FAR. And we were a very long way from that 11 years ago. And that caused us to do a lot of things strategically. So, and we all talked in one way or another about scale. Scale is table stakes for us to be most trusted for personalized coordinated care. So we built horizontal scale and vertical scale. Today, we're the largest provider of home care in Connecticut. We're the largest provider of behavioral health in Connecticut, on and on. We've built that continuum. And that scale is only a table stakes. It's only the entry into being able to achieve that vision for us. And the second piece of our strategy was to tightly integrate our operating model from governance on down. We had to build, because we know we were going to be competing with much more agile organizations than the ones we had traditionally been competing with. So we have a very tight, deeply integrated and implemented operating model that allows us to move very quickly. We built a promise to those we're serving based on both the vision and the way we were organizing ourselves, and that was what we called our 5 1s. And our delivery of those 5 1s were going to be 1 registration, 1 health record, 1 standard of excellence, 1 financial statement, and 1 relationship. And those were going to be the manifestations of our vision from patient or consumer point of view. And I want to underscore the relationship piece, because that comes back to who is disrupting us and who competes with us increasingly. The battle in our mind, in our marketplace, is for the relationship. Everybody wants that relationship. So we have to build an organization, and that's where disruption and innovation play in our mind. And I'll stop there, but more to be said.
Yeah, so everybody needs to really dwell on that whole relationship issue. That's why CVS calls their new initiative a new front door for American healthcare. Correct. Because what everybody's trying to do is, where the disintermediation is occurring, is people are trying to get in between their traditional caregiver and the patient. And with the general approach feeling is that if you get in between there, then you'll take away more of the care, and then more of the revenue will naturally flow to your organization. So that's the competitive piece. So those comments were extremely helpful. Right, I know that there's sort of the feeling that at times that healthcare organizations need to feel like they have to do it all, but they can't do it all. And so I know that you've been exploring some partnerships about how to get things done more efficiently and better. Could you comment on those?
Sure. So, I think just piggyback on this notion of relationship. So for us, that really is key. As we think about what our role is in the healthcare ecosystem, we think that our goal is to focus on managing aligned lives in communities, not running hospitals, but aligned lives in the communities we serve. And so when we think about partnerships, we think about it pretty broadly, frankly. You know, a lot of people have commented in the last few months on a partnership we announced with General Motors around GM Connected Care, where you know, a large employer who's been searching for a long time to find ways to address the health and wellness of their employees, and frankly have tried a lot of things and as most have done, have failed at a lot of things, you know, said to us, you know, would you help us around value, around access, around quality, and around cost management and overall health of our employee base. And so our Connected Care partnership is a unique one where, you know, as we say, both organizations sort of opened our kimonos, if you excuse the expression, to sort of talk about how do we really work together and share costs, share pain, share incentives, and hopefully share the outcomes of healthier employee population. You know, one of the things that I get really excited about is technology. So while I'm not trained in technology, but I began my career 30 years ago with a CEO who said, I would like to remove all the paper from our healthcare system because it's a waste. And so I think about artificial intelligence, and some of our prior presenters talked about that. Henry Ford has, over the last 3 years, sponsored an artificial intelligence competition with startup companies, frankly, in Israel, to help us solve a problem. And so our clinicians and our administrators put together an issue, and we put that out to 40 or 50 companies to ask to have them help us solve it. So for instance, today we're trying to solve the issue of overuse of imaging and using artificial intelligence to help our clinicians make better decisions to reduce the use of imaging to drive costs down. When we think about the Henry Ford promise, not unlike what Elliott highlighted, so for us, we use the term True North as sort of our commitment to the communities we serve, and we say that, and again, not unlike Elliott's organization, we strive to be the trusted partner in health, leading the nation in superior care and value. And in doing that, we think about safest care and best outcomes, exceptional experience, affordable care, and inspired and compassionate people who all revolve around the customer, right? And to Dr. Howell's commentary, when we talked about customer, a lot of our clinicians said, don't call our patients customers. They're not customers. They're seeking our help. They're seeking our guidance. And what we said is, we're engaged in a trusted partnership relationship with this individual who does need our help. But if we don't treat them like Nordstrom's treats their customers, or like Amazon treats their customers, or like a physician in a patient relationship who wants to be that trusted individual treats that patient, we're not going to win. The last partnership I would mention is we're really trying to restructure our approach to the consumer and his or her experience. And so we're partnered with an organization called Accesso, who's bringing us something called the Experience Engine, which is helping us sort of reimagine the customer and patient experience across our enterprise. And so we're starting with cancer care because, you know, if any of you have had family members or if yourself have experienced cancer, you know that our health system oftentimes fails our country when you're seeking cancer care because it's so complicated and there's so many cross bridges. And so what we're trying to do is to completely eliminate all of the cross bridges. And we don't have the terminology that Elliott did around the 5 1s, but it's a similar kind of concept where we expect to know who you are when you drive up to the building and know what your issues are and have someone greet you and say, Mr. Joseph, you're here for, let us get you to X, Y, and Z, and after that you'll do this, and that we anticipate your needs and we treat you as if we know what we're doing, not asking you the same thing 5 times in a situation. So those are a couple things.
Janice, what are you guys doing in looking at new care models, and how are you trying to change that care delivery system in order to be a much more contemporary organization?
Yeah. So I think that there's a remarkable alignment and synergy here in terms of how we're thinking about the future, which is really great to hear. But so I would say a couple of things. One, sort of again, really investing in data. So we were the recipients several years ago of CMMI funding, and then made our own investment. And we have created a data platform that is truly unique in the sense that it can ingest data from pretty much any source. And because we have such a powerful HIE in the state of Delaware that gets feeds from our neighbors in Maryland, Pennsylvania, and South Jersey, we can actually create data that reflects sort of the real-time clinical experience of the people that we're serving. And embedded in this platform is AI and machine learning, so we're continuing sort of to refine what's in that platform. On top of it sits a predictive analytics engine that can actually sort of sort out who's at risk today in the moment and set alerts. So our virtual care team, which is multidisciplinary physician, nurse, pharmacist, social worker, behavioral health therapist, diabetes educator, even a loneliness counselor, can then deeply understand what's happening in the moment and reach out to that patient and actually change the trajectory of care. So we know, for example, that a patient who's a member of the population that we're serving through this data platform is in the emergency department before they've even seen the physician. And so again, it allows for that reach out and the ability to really personalize care. We're working deeply with primary care clinicians, so there's a real sort of back and forth. Again, agnostic to EHR, which solves that issue. But that's another sort of big place where we're investing. You heard it from the panel previously. If we're going to create value, we need a very strong foundation for primary care. So we are in the midst of more than doubling the number of lives that we're managing through primary care. And at the same time, we're reimagining primary care. There are serious workforce issues. There will never be enough people. So we are figuring out how do we work differently, both when it comes to people and the teams that we're creating, but then how can we use technology, some of the new technology, so that we can create what we're calling radical convenience. It's all about that relationship. It's all about that experience. We want to be there for you whenever you decide that you need us. And I would say even more, using this data and the technology that we've developed, we want to be able to reach out to you and engage you at a moment that you may not even realize you're at risk. But because we have created that relationship, we can do something different and manage the outcome differently. As I mentioned, we've got about 100,000 lives that we're managing on this platform, about 50,000 Medicare beneficiaries, but we also have a relationship with the state. We're managing about 30,000 state employees and dependents, our own employees and their dependents, and a whole variety of smaller niche programs. But across the board, we've been able to demonstrate improvements in quality, reductions in costs, delight from both the patients and the families and the providers. And it's taught us so much about how we also need to engage differently with our community. To the point that has been made several times, we can't do this alone, and some of those new partnerships that we need to forge are deep partnerships with the resources that exist in the community so they can partner with us and impact health.
So do you think that the patients are noticing the changes you're making in the delivery system, especially the 130,000 that you have under management? And do you have a way of assessing as to whether they're seeing you differently relative to their new competitive choices?
I would say absolutely. I mean, we measure the impact of everything that we do. And just imagine this, you've been discharged home from the hospital, maybe having had a TIA. You walk in the door and you get a call, and the person is making sure you got home safely, is reviewing your discharge instructions, is facilitating next steps for you, is understanding, do you need, making sure you're taking your medications, providing you with home monitoring devices that then feed to this platform. So really, that kind of experience delights people. They're not used to it. And so I think no surprise, the outcomes in terms of experience that are there for those people on this platform has really been extraordinary. I think what has surprised me, and probably shouldn't have surprised me, is the delight that the primary care physicians are experiencing with this, because they've never before had access to the kind of services that we're providing virtually. We deploy iPads into the physician practices so they can, in the room with the patient in rural Delaware, they can connect with a clinical pharmacist. They've never had that resource before. And so, I think that, again, using technology, we talk about algorithms for empathy. And it's not just about the patient, it's also about the person who's providing the care.
Wonderful. So Elliot, obviously, as Janice has talked about, digital capability is going to be critical here. And I've heard a lot of comments that Google probably has more people writing code than all the hospitals in the United States combined. So how are you thinking about this digital problem in Hartford?
So before I go there, I'm going to take advantage of sitting here for a second because someone mentioned we have regulators in the room. So Rick, don't get nervous. I'm going to stay in the lines. But I have what I think is a simple request for you to consider. If you could eliminate the word discharge in your regulations, that would really help. I'm trying to eliminate that word in our organization, and it goes back to our vision. And part of what we bump into is all the regulatory language around the word discharge. So just a plug for those of you who could help us. I think that would benefit all of us. So
Your logic being the patient is never discharged from the Hartford
Think about the word
organization.
discharge, first of all, right?
It's like
is
it's
there
like you
anything
go
good about
away.
discharge?
No.
No. And that's what we say we do, right? And it's a transition. It is this fully coordinated, less fragmented, less size.
Excellent point.
I'll step off of that.
Very good point.
So back to the question that you asked, Gran. So we're in our infancy in this regard, and it does get back to a word that Janice used, which is partnerships. And we are seriously outpersoned against our new competitors in this arena. It's a frightening proposition in some ways to think that I've got a bunch of hospital people fighting this battle with these tech giants. It just doesn't work. So partnerships have been critical. A couple of examples of this. We've partnered with General Electric in using their predictive analytics, and we've created something called a Care Logistics Center. And for the first time in my many decade career, we're now actually maximizing right now we're on the inpatient side, maximizing the inpatient capacity of all of our hospital beds all across Connecticut, all 7 hospitals. And we're able to move patients with one phone call. We've got a very large room with 50 or 60 people, critical care physicians, critical care nurses, bed management people, all with all of our bed capacity across all of our hospitals. Never been able to do this before. It is having profound positive impact on everybody across the community, across the state, and within our organization. We could never do that before for not only the lack of technical capability, but just an organization that couldn't function that way until recently. Another example is our urgent care partner. We've partnered with a private equity-based firm. We've put up 17 urgent care centers in the last 18 months. We're going to approach almost 250,000 visits. These are people who come to our industry from retail and technology. They're not healthcare people. They've literally reimagined urgent care in a way that the net promoter scores are 85. Unheard of numbers, busting through the roof. We also, the last one I'll mention is we have a partnership with MIT. And the MIT folks are working with us in our ORs around maximizing utilization, staffing, scheduling, all using digital and predictive analytics capability in a way, again, our current team would have no ability to be able to bring to fruition. So there's a lot of exciting things starting to percolate and take hold and starting to make a difference.
Terrific. Thank you. So one of the great challenges in American healthcare is dealing and treating with pluralistic communities, different kinds of communities that approach healthcare in a different way, and different capabilities of paying for that healthcare. So certainly in Detroit, you have challenges with uninsured and other patients who struggle to pay for your services. How is this influencing your strategies to be competitive now in the future, and how's that integrating with your strategic plan?
I would sort of start off with with the presumption that when we look at a community, you know, what I say to our team is that it doesn't really matter what someone brings to us. The approach should be that we're trying to achieve the same goal, which is to establish health and wellness in that community. And so whether they're fully insured communities, commercially insured communities, self-insured communities, high uninsured, Medicaid, Medicare, we start with the notion that the goal is the same, irrespective of the resources or the socioeconomic factors, right? Having said that, clearly when you serve urban communities that have high degrees of vulnerable populations, you have complications that don't exist in purely suburban climates. And so in Detroit, we have all the things that you've heard about in the news. You hear about all the negative stuff, and then there's a ton of positives, some of which you hear and some of which you don't hear because we like negatives more than positives in our media. And so we focus on a number of things. First, you know, we're an organization that has a large health plan along with our clinical delivery system, and so we leverage the fact that we have 600,000 people in risk-based insurance arrangements as part of our approach to delivering health and wellness in the community. We have a very comprehensive focus on health equity, community health and wellness, diversity and inclusion, and so a lot of our activities are really focused on how do we look at targeted interventions. For instance, Detroit has one of the highest infant mortality rates in the country. It's not something that we're proud of, but it is what we deal with. And so we spend a lot of our time and effort focusing on innovative ways to address that. And so we have, for instance, something we call the Women Inspired Network, which is really focused on using customized interventions to address the issue of prenatal care, the issue of lack of access, lack of transportation, lack of social support for mothers during that prenatal period. We use, at times, non-traditional caregivers to deliver messages and connection to communities differently than just using the traditional OB-GYN physician, for instance. We have outreach pilots in barbershops because that's a place to get to some parts of the community that you're not going to get in, for instance, in some heavy African American communities. The best way to get to men is not to expect them to come to the doctor, it's to go to barbershops. We've done pilots with postal workers to assist us in providing non-medical follow-up with patients in difficult communities that we've piloted. And so, you know, I would just say that, and I won't talk about things like uncompensated care and the things that we're challenged with, but I think when you deal with urban and vulnerable populations, you will have lower margins in healthcare than you have in suburban populations. You will have higher charity care and higher uncompensated care. And so what it requires you to do is, frankly, to be more lean. And so on everyday basis, we have a dozen to a dozen and a half teams that we call system design and transformation that are focused on adding value to our clinical engagement process, but reducing the cost of care to address the affordability issues around care in vulnerable communities. I mean, so those are a couple examples that we're focused on that try to help balance the fact that we don't serve a full, highly educated suburban population where everyone's employed and everyone's insured.
Great, great. So Janice, as a physician, obviously the physician's role in everything that the three of you have been talking about is going to change really dramatically. Could you sort of discuss your view of that change? And I'm personally sort of concerned whether physicians are going to be able to make the pivot. You know, you've got a number of dimensions in healthcare delivery. I'm pretty sure that hospitals are going to be very flexible in how they approach it, but doctors at the moment seem very inflexible about it. So maybe you could comment on that.
So thank you for asking that question, actually, because I think there's so many conversations that we have, and nobody seems to remember that physicians are integral to healthcare. You know, if we didn't have physicians in our hospitals, we wouldn't be
why do we need doctors,
we
right?
wouldn't be doing it. So, you know, I think I share your concern. It is, I think Mike said this, it's always been challenging, highly rewarding, but challenging to provide care. And I think the current environment is making that even more challenging. And it starts with, you know, how we train physicians, how we recruit physicians into medical school, then how we train them when they're medical students and residents, and then how we support them. So, you know, I think it's imperative that we find ways to engage physicians. Physicians are really smart. Physicians really care about their patients. And that's why I'm optimistic. And if we can create the right structures to bring them in, respect their perspective, give them the opportunity to lead, you know, I think that they can become really sort of vital partners in how we do all of this transformation. They know where many of the pain points are. And we also know, I feel some urgency around this because, as you know, the whole issue of clinician burnout has really become sort of a front page. And there's so many places, including Christiana Care, that are doing, I think, really sort of leading work in how do we identify burnout, and then how do we support people who are burned out. But we've got to figure out how to get further upstream. How can we prevent people from burning out? How can we make sure that that passion, that mission that they brought to their healthcare career is still there 10, 15, 20 years later? And I really do think that that comes through engagement, but it also can be enhanced by technology. So, you know, the electronic health record, as Brian mentioned, is a source of pain. We're using Google Glass and a software product so that it's taken out that essentially is a digital scribe, so that physicians get to look at their patient and interact with their patient, spend more time with their patient. And literally they will say, this gave me 2 hours back in my life to cook dinner, to be with my kids. And that, again, that is, you know, where we need to continue to invest. So we are, you know, certainly we train folks. We work with them to manage burnout, prevent burnout, and we also really work to engage them both as leaders and as partners. And again, I think this is where one of the reasons why the modernizing Stark and anti-kickback is so important, because there's a large private practice community out there, very important to the overall delivery system, struggling more perhaps than others. And there are ways that we can partner to provide them with the tools and the support that they need to be effective, but frankly, there are some barriers to that currently. Yeah. I think if we don't do that, you know, there's a real potential for the system to break. It's that important.
Great. Okay, now we're on to questions. So I promised Rick I would only take good questions. So let's have let's have some good. You've got a unique opportunity here, so let's get some questions. Right over here. There's a question over here.
She's got a mic right there.
I got a mic. Okay. I'll jump in, and I hope this is a good question. Hi, I'm Sarah Dash. I'm president of the Alliance for Health Policy here in DC, and thank you so much for this panel. Super quick comment, Elliot, when you mentioned the word discharge, it just reminded me of a speech that Don Berwick made back in 2000 that he titled Dirty Words and Magic Spells, and when he said patients do not want to be discharged, they want to be remembered. And I just remembered that. But my question for all of you.
Do something about it, please.
So there you go. So thank you. My question is about the workforce, and each of you has mentioned it in different ways. And on the previous panel, we talked about 2,000 people at the Cleveland Clinic just doing revenue analysis and how AI might help to influence that. My question to you is, if you look into your crystal ball 10 years down the road, what does the workforce of the future look like that really supports your goals to reach the community, to deliver patient-centered care, to support the clinicians? How do you see the broad trends changing? How would you like them to change in your ideal world?
So I'll start with that with an answer, and I maybe won't answer it exactly as you asked, because I won't answer it the way that I want it to be per se, because since I don't have a magic wand, I don't know that it will be exactly the way I want it to be. But I will start with this. The double-edged sword around the answer to that question begins with the role that hospitals play in local communities. And so, like it or not, hospitals oftentimes are the largest employer in many communities served. And so, to some extent, one of the challenges that we face is that as we think about deploying technology, improving productivity, we also, on the other hand, are faced with the pressures of, but you also are oftentimes the largest and most diverse employer in the community you serve. And so whatever you do to transform your workforce should take into consideration the overall economic development of the communities that you're serving. Having said that, my view is this: I think that we'll have a lot less customer service, consumer-facing people in our workforce than we do today. And that's not my wish, but I think that as you think about the deployment of technology, as you think about how we interface with patients accessing our systems today, my sense is that's one of the ways that we can continue to automate, to use technology in ways that hopefully improves the interaction, that has us asking less of the same questions to individuals seeking our services. And so I think we start off with the notion that we have to get comfortable with, we likely will have less consumer-facing individuals than we do today. I think what you've also heard from my colleagues here is that we will have more people doing things focused on leveraging technology, analytics, and really predictive analytics, not just retrospective. We've been very good at retrospective, we've been very deep in retrospective analytics. And so I think that we will have more folks doing that, but I think that will never be our primary job. I think that might be the primary job of partners as opposed to the primary job of the healthcare systems of the future. I think that we will need to continue to evolve how our licensed professionals are utilized, nurses, pharmacists, social workers, and the like, so that one, they're at the highest end of their license, but also supported in a way that removes the ugly trend that's happening today around burnout and folks who frankly want to get out of the boiling kettle, so to speak. And so I'll stop there so I don't take all the answers from Elliot.
Yeah, so I'm going to give you probably an unsatisfactory generic answer because I have no idea what the answer to that question is. But culturally, in terms of the kind of person we want coming to work in our organization 10 years from now, probably even now, is very different than people who've typically migrated to hospitals and healthcare work. I feel like most of us who've migrated there over the course of our career, and I'm obviously generalizing quite broadly, are people who are tradition-bound and are looking for stable environments. Janice and I were talking about this before we got started this morning, and we ended up in a very similar place. In our organization, I've asked our HR team, as they think about recruitment, that I want our recruitment slogan to be "strap in." Right? If you hear that slogan and you don't like it, don't come to work for us. Janice says, buckle up, right? Coincidentally, we had the same thing going on. So this is about change. This industry is about change and change management and innovation all of a sudden, right? Those words did not really apply over the last number of decades in our industry. So I'm not smart enough to figure out, the whys and what fors and who's of what technical or clinical skill is going to shift over time. But the culture of the kind of people, the people we want to draw into our culture as we continue to build this new kind of organization, look a lot more like people who might go to work in a tech company or a vertically integrated healthcare organization. I won't name any names.
I just want to acknowledge that on the record, and I'll tweet it out later so it's official, that for Henry Ford, our new HR mantra will be "Hold on."
That's great. Yeah, and the startup Buckle Up and Hold On is all about. I think we're all really excited about what's happening in healthcare, and I think it is one of the, thinking about talent and what we need in the future is one of the things that I think is a top of mind issue, and to be additive rather than repetitive, because I think my colleagues have made some great comments. I also think we have to pay attention to what are some of the emerging technologies that will require us to have a workforce that's trained differently. So for example, gene editing. We have a gene editing institute. I think we're the only community-based academic health system that has one. And one of the things that I'm most proud of in terms of the work that they did was they got a grant from the National Science Foundation to accelerate their work. But part of that was to create a curriculum at the Delaware Deltech Community College to actually create the workforce who could do the lab work that's needed for that new and I think incredibly innovative and potentially transformative part of healthcare.
We had a question over here. Oh, we're going to have a question right here. Sorry.
Hi, my name is Amy York, and I'm with the Elder Care Workforce Alliance. We're a coalition that represents really the whole care team, including family caregivers, consumers, and the professional care team, and direct care workers. And older adults haven't been really focused on much up here. You've kind of skirted around it and talked, I think, about some of the care that's provided. But I'm curious, first of all, what you're doing to help train your workforce in the care of older adults and to make your institutions age-friendly. And particularly, I know there's been a lot of work around emergency rooms and how we can make emergency rooms more age-friendly. But in general, too, what are you doing to focus on the care of older adults?
That's a wonderful question. So I think there are opportunities at sort of every piece of the continuum to think about that issue. So just to mention a couple of things. On the acute care side, we have units that are acute care for the elderly units. They're physically designed to support the frail elderly and their families and all of the various parts of the health system that are needed for acute care. They are, I think it's NICHE niche certified, and we have a program called We Improve Senior Health that takes that approach beyond the ACE units and into the rest of the environment. And then on the, there's a lot to talk about here. One of the programs that I'm passionate about, because I think it's been extraordinarily successful and is under the radar, is Independence at Home, which was a CMS demonstration project. And we were one of the participants. We remain a participant, even when the program had a period of time when it was unauthorized. We care for about 800 frail elderly in their homes at any given time. We've had thousands go through this program. It is extraordinary. The cost reductions have been, I think, transformational, because this is the group of people that are at the end of their life, and healthcare costs are exorbitant. But more importantly, to be able to work with patients, elderly patients and their families, and give them that comfort of knowing that they're getting the care that they need in their home, I think is incredibly rewarding. I think it's a program that is not on, that doesn't have long longevity. I understand there may be some changes coming. I would strongly encourage the people who can do this in the room, look at that program, look at the outcomes, and let's do Independence at Home 2.0 for many more of the frail elderly who live in our communities.
Okay, I think we're at the end of our time. Sorry. I'm sure we could go much longer. Please thank our panelists for taking their time.
Thank you, Ken, Elliot, Wright, and Janice. Appreciate your being with us here. Thank you very much. Just a couple of wrap-ups while I know people have to catch planes here. On that last question, I might add that Our research foundation has a relationship with the John Hartford Foundation. In fact, we received a grant to really focus on this whole notion of age-friendly care. Just a couple of quick takeaways. I think what you continue to hear is the issue of partnerships between hospitals and health systems with folks in the data and technology area, all directed at trying to improve the patient care experience. I really am pleased that the issue of workforce came up because that is obviously so important. And through the AHA's Physician Alliance and through our organization of nurse leadership, we are really focused on the issue of improving the workforce. There are so many dimensions of that in terms of our workforce practicing, as was said earlier, to the top of its license, of training folks to be able to provide care outside of the traditional settings of our buildings, to building cultural competencies as we strive to take care of diverse populations that we see as becoming more important in the future. And trying to deal with issues around violence. You know, one of the challenges when you talk about burnout is the issues that our providers confront related to workforce violence in the workplace. And a lot of that stems from issues around opioid abuse and issues related to behavioral health. And we even have our own Hospitals Against Violence campaign. And then the last thing, and don't let's not get it lost, modernizing regulations. You know, Elliot put the issue of discharge and that word on the table. But, you know, the Stark laws in particular really, as Janice was saying, are obstacles for hospitals and physicians to work together and be aligned. And those laws were created in the 80s for a whole different system that existed at the time. And the compensation models for that really need a new look. And in that regard, the administration, they've sent signals from the top that they are really focused on updating and modernizing those laws. So Yogi Berra once said that it's tough to provide predictions, especially about the future. I prefer the quote from Abraham Lincoln, which he said the best way to predict the future is to create it. And as the healthcare shifts from a value-based system toward a value-based system, we're trying to build sustainable, coordinated networks with the scale and scope to innovate, to compete with new entrants that are entering the healthcare marketplace, and more importantly, to make care better for the people that we serve. What we really heard today are efforts where we seek to create organized networks of caring that provide care in a coordinated manner that is seamless so that patients don't get bounced around from one unconnected facility and provider to the next. So I hope you leave here remembering two things. The first is that today's healthcare environment is like nothing we've ever seen before. And second, that hospitals and health systems are partnering to drive innovation, to improve quality, expand access, and provide a better patient care experience. While today's event only lasted 2 hours, we'll continue these discussions with policymakers, with the media, and other stakeholders. In fact, the AHA team will make themselves available, particularly to any media folks, right after this. So we appreciate your being here today. I know that all of you will stay focused on these issues as we work together to advance health in America by saving lives and keeping people healthy. Thanks so much for joining us.